Good morning. Today's session is about role of periodontal flap surgeries in correction of periodontal pockets. So we know that periodontal pocket therapy, they form an important segment in periodontal therapy. So periodontal surgeries, they are of different types. Among this, one of the major indication for periodontal surgeries is in the correction of periodontal pockets. So first we should know what is a periodontal flap. So a periodontal flap, it is a section of tissue or mucosa that is being separated surgically from the underlying tissues in order to provide both visibility as well as access to the underlying bone or root surface. So why do we need periodontal flap surgeries? So one of the major indication is in the correction of pocket. So we have periodontal flap surgeries for the correction of pockets. Apart from that, we have periodontal flap surgeries in order to provide an access to the underlying root surface, to the underlying bone, for the maintenance of oral hygiene. We have surgeries for lengthening the clinical crown, as well as to regain the lost periodontium using regenerative approaches. So here we can you can see a periodontal pocket. In the first picture shows a normal gingival sulcus, whereas in the second one you can clearly visualize a change in the position of junctional epithelium. Junctional epithelium has shifted downwards, as well as there is a gingival enlargement. So the sulcus has deepened both apically as well as coronally. So this is a case of true periodontal pocket, as there is shift in junctional epithelial attachment. So this periodontal pocket has got a soft tissue wall as well as a hard tissue wall. This is the soft tissue wall, and the other portion is the hard tissue wall. Both these surfaces harbor microorganisms as well as their products. So it is necessary to remove both these surfaces in order to create a maintainable state of periodontium. So the purpose of pocket therapy is to eliminate soft tissue wall as well as hard tissue wall of periodontal pocket, or to eliminate all the pathologic changes in the pocket wall, elimination of soft tissue wall of the pocket, and correction of all the changes in the hard tissue wall of the periodontal pocket, and ultimately to attain an easily maintainable state of periodontium as well as to promote regeneration. So what are the indications of periodontal flap surgeries? Apart from pocket therapy, apart from pocket eradication, pocket reduction, or otherwise pocket elimination, the flap surgeries are meant to correct deep craters, irregular bony contours. They are also indicated in case of management of percussion involvement, in case of intra-bony pockets, distal to last molars. So periodontal flap surgeries, they are mainly indicated when inflammation is persisting in areas with moderate to deep periodontal pockets. However, they are contraindicated when patient has got poor oral hygiene, poor patient cooperation, then poor prognosis. Then they are relatively contraindicated if they are medically compromised, like in case of uncontrolled diabetes, uncontrolled hypertension, myocardial infarction, patients under anticoagulant therapy, hormonal disorders. They are not definite contraindications. All these are relative contraindications. That is, in a hospital environment, with all the precautions and all the necessary requirements, or all the support when in a hospital setup where all medical setup is available, we can always manage a patient with a medically compromised situation if their situation is under control. That is, if their medical problems are under control. Now coming to the principles of periodontal surgery. So whichever the surgery will be, one should always analyze a patient. One should always analyze the situation One should always take a proper case history, analyze their medical history, should develop a proper treatment plan. They should have a proper knowledge of the anatomy of the surgical sites. There should be proper anesthesia. One should always follow aseptic surgical techniques. Then tissue management should always be atraumatic. Then we should attain proper hemostasis after the surgical procedure and always use atraumatic suturing techniques. Then before the surgical procedure itself, so one should go for a proper case history taking, including assessment of all the risk factors. Then assessment of oral hygiene is highly important. Before the surgery, the surfaces should be 80%, should have 80% of plaque free, should be 80% plaque free. And always patients, all the risk factors, everything, all the benefits of the surgery, everything should be discussed with the patient. Then pre-medication if necessary. Surgical instruments, everything should be properly sterilized. They should be sharp and properly maintained. And informed consent has to be obtained before any surgical procedure. Then even after the periodontal flap surgery, the suturing technique should be atraumatic and it should always attain a closure of dead space, or after the suturing, there should not be any dead space between the flap as well as the bone. And we should take all the measures in order to promote a proper wound healing. So coming to the incisions in periodontal flap surgery. So we have basically horizontal incisions as well as vertical incisions in periodontal flap surgeries. Horizontal incisions are incisions placed parallel to gingival margin or following the gingival margin. The three main horizontal incisions in periodontal surgeries are internal bevel incision, otherwise called first incision. Then we have crevicular incision or sulcular incision, then interdental incision. In this, the first one, what you can see is an internal bevel incision. This incision is placed with a number 15 blade, usually directed at the crest of bone from 0.5 to 1 mm from the gingival margin. The main objective of internal bevel incision, the main objective of internal bevel incision is to create a sharp, thin, knife-edge margin and to preserve as much as keratinized tissue as possible and to eliminate this soft tissue lining of pocket. So these are the different directions in which internal bevel incision can be placed. So these are the objectives of internal bevel incision. See, the second one is crevicular incision or sulcular incision. Crevicular incision is placed from the base of the pocket towards the bone. It is placed following the sulcus from the base of the pocket to the bone. That is crevicular or sulcular incision. Then we have interdental incision. Interdental incision is placed in order to remove the remaining collar of tissue after the crevicular as well as internal bevel incision. Internal bevel incision can be placed at different levels or different angulations according to the situation, according to the surgery, according to the requirement. We can modify the angulation of internal bevel incision. So, in general, the internal bevel incision is done from a common point in case of surgeries like modified Bridgman as well as apically displaced flap surgery. See, this is where we place an internal bevel incision that is 0.5 to 1 mm from the gingival margin towards the crest of bone. This is the area for internal bevel incision in case of modified Bridgman and apically displaced. Whereas in case of undisplaced flap surgery, internal bevel incision is placed towards the lateral aspect of bone. Internal bevel incision should always, this is where we have placed the internal bevel incision following the scalloping, following the gingival margin. It should always it should follow scallop. It will, the extent of scalloping will vary for undisplaced flap surgery as well as for apically displaced or modified Whitman. It will be almost the same in case of modified Whitman and apically displaced, whereas it will be slightly exaggerated in case of an undisplaced flap surgery. Now coming to vertical incisions. There are certain principles, vertical principles to be followed by placing a vertical incision. A vertical incision should never be placed on prominences, that is on root prominences, on prominence of root. It should never be placed bisecting an interdental papilla. It should either involve the papilla or it should exclude the papilla. Then flap surgeries without vertical incisions, usually they are called, it will be an envelope flap. Whereas incisions sometimes in certain flap surgeries, in order to provide better access to the underlying tissues, we may have to include vertical incisions, either single or double vertical incisions on either end. The vertical incision, when we place a vertical incision, should always extend beyond a mucogingival junction. Coming to the flap design and flap reflection. Whenever we go for a flap surgery, we should design it in such a way that the base of the flap should be wider. Its blood supply should never be anchored. So that base of the flap should never be excessively twisted, stretched, or grasped with any instrument, because it can damage the vessels, it can hamper the blood supply, it can hamper the healing. Even after the procedure, the healing will get affected. Then how will we reflect a flap? Flap, they are of different types. It can be a full thickness flap or a partial thickness flap. If it is a full thickness flap, otherwise called mucoperiosteal flap, this is usually reflected with the help of a periosteal elevation. Whereas if it is a partial thickness flap, you have to go for a scalpel or a blade in order to split the mucus, split the connective tissue in order to raise a split thickness flap. You cannot deflect a split thickness flap or deflect split thickness flap with a periosteal elevator. It is meant to, periosteal elevator is meant to elevate mucoperiosteum from bone. This is how you elevate a full thickness flap or a mucoperiosteal flap with a periosteal elevator. This is how you reflect a split thickness flap with a scalpel. Now coming to the flap surgeries in pocket therapy. So we have periodontal, different surgeries are involved in periodontal pocket therapy. Among them, the first one is gingivectomy. They don't come under periodontal flap surgeries. So we are not discussing gingivectomy here. Here we are discussing only the periodontal flap surgeries in correction of pockets. And which are the periodontal flap surgeries involved in correction of pockets? We have basically three surgeries: modified Whitman flap surgery, apical displaced, as well as undisplaced flap surgery. Modified Whitman flap surgery, it was introduced by Ramford and Nissel in the year 1974. This is mainly indicated in areas with moderate to deep pockets. This surgery also helped in correction of underlying bony defects. They are mainly indicated in anteriors. Usually they are not that preferred in posteriors. Now let's see the steps in modified Whitman flap surgery. The first incision or the internal bevel incision in flap surgery, in modified Whitman flap surgery, is placed 0.5 to 1 mm from the gingival margin towards the crest of bone. That is the first step in modified Whitman flap surgery. Then this is followed by the placement of clavicular incision from the base of the pocket towards the bone. After that, a flap is full thickness flap, mucoperiosteal flap, is elevated using a periosteal elevator. Then with the help of number 12, number 11 blade, we have to remove the remaining corner of tissue, that is using an interdental incision. See, this is the remaining wedge of tissue that is remaining there. It is to be removed by an interdental incision. after which all the granulation tissue tags present are removed. Bone contouring is done if necessary. The areas cleansed with saline. Then the tissue is then, flap is then kept back. It is adapted to the underlying bone, and it is sutured either by interrupted suture or by using continuous sutures. One should always apply pressure over the flap for around 1 to 3 minutes in order to obliterate any kind of dead space between the flap and the underlying bone. So these are the advantages of modified Whitman flap surgery. In modified Whitman flap surgery, there is minimal loss of tissue. There is it provides opportunity to modify underlying bone, and there is less exposure of root surface. So it is a major advantage from an X3 point of view. However, this particular technique does not result in pocket elimination, and this surgery will also result in healing by a long junctional epithelium, which is always more susceptible to further degradation by the presence of plaque. It is not a stable or not a strong attachment. Now coming to undisplaced flap surgery. This undisplaced flap surgery is otherwise known as internal bevel gingiviectomy. Here, this particular technique is indicated in areas where there is, it's not indicated in areas where there is insufficient attached gingiva. This technique is indicated, or the main advantage of this technique is complete pocket elimination. In this technique, what you have to do is first you have to mark periodontal, you have to measure the periodontal pocket and mark the depth of pocket using pocket markers. This is how you determine the depth of pocket using pocket marker. You have to then connect these bleeding points that is being formed by pocket marker. Thus, the incision lines are determined for the placement of internal bevel incision. You have to connect all these bleeding points following the curvature of root. That is, it should be scalloped. It should be scalloped. Then, after the internal bevel incision, go for crevicular incision. Like modified Whitman flap surgery, go for sulcular or otherwise crevicular incision along the sulcus. That is, from the base of the pocket towards the bone. Then the section of tissue is removed. This is followed by interdental incision. Then internal bevel incision is placed from this marking towards the lateral surface of the bone. So that is different. The direction of internal bevel incision is different in undisplaced flap surgery when we compare it with modified Whitman flap surgery. In modified Whitman flap surgery, the internal bevel incision was directed towards the crest of bone, whereas in undisplaced flap surgery, the internal bevel incision is directed towards the lateral surface of bone. And the incision, you have to start the incision from this area. See, you have to start this incision. This is the marking after connecting all the bleeding points. You have to start the incision either along this marking or slightly coronal, or from a point slightly coronal to it, directed towards the lateral surface of the bone. Then you have to remove all the granulation tissue. This bench of tissue is removed. All the granulation tissue tags is to be removed. Bone contouring is to be done if necessary. Then the tissue is then placed back at the tooth-bone interface or bone-tooth interface. That is another difference. So that in undisplaced flap surgery, there is complete elimination of pocket. Now coming to apically displaced flap surgery. This is another flap surgery in which there is complete elimination of pocket. But the major advantage when we compare it with an undisplaced flap surgery is that here there is preservation of keratinized tissue, or there is minimal loss of tissue. Apart from that, the surgery will also result in some amount of increase in width of attached gingiva. So now where are they indicated on this apical displaced flap surgery? They are mainly indicated in moderate to deep pockets where base of the pocket is apical to mucogingival junction. This particular technique is also can also be carried out for crown lengthening in management of grade 3 percussions for the increasing the width of keratinized gingiva. However, they are contraindicated if patients are more concerned about their aesthetics, if there is high chance for caries, high chance for sensitivity in such patients who are prone for sensitivity in such cases, this particular surgery is contraindicated. Now, coming to the steps in apically displaced flap surgery. So, apically displaced flap surgery, first, it involved the placement of internal bevel incision, 0.5 to 1 mm from the gingival margin, aimed at the crest of bone. This is followed by clavicular incision. Then, it should also involve vertical incisions. When we vertical incisions, both on either ends of the flap, it should involve vertical incisions without bisecting a papilla, without it should never be on the prominence of the tooth, and this particular incision, vertical incision, should extend beyond the mucogingival junction. Then you have to reflect the flap, remove all the granulation tissue, bone to bone if necessary. Then place the flap back at the bone to interface. So in this technique, there will be some amount of exposure of root. That is why this technique is not indicated in patients who are more concerned about their aesthetics, who are prone for caries or prone for sensitivity. In such patients, they are not indicated, but here there is minimal loss of tissue. Apart from that, there is complete elimination of pocket. So, we saw different surgeries, periodontal flap surgeries, as well as their role in periodontal pocket therapy. So one should have always a proper understanding about the incisions in periodontal surgeries. Incisions in periodontal surgeries, the flap elevation techniques, flap elevation techniques in periodontal surgeries, the different surgeries involved for the correction of periodontal pockets. Here, a modified Whitman, apically displaced as well as undisplaced. These are the advantages of apically displaced flap surgery: pocket elimination, optimum soft tissue coverage of alveolar bone, and a minimal post-surgical bone loss. And even in the surgery, the post-operative position of gingival margin can also be controlled. And here the pocket wall is converted to attached gingiva. However, the main disadvantage is exposure of root surface resulting in aesthetic problems and root sensitivity. So that is about the periodontal pocket therapy by different periodontal flap surgeries. Thank you.